All right, so anxiety disorders, really quickly, I'll just go through the general information. You guys know what anxiety is. You guys have had anxiety. Now, this is specifically more like talking about generalized anxiety disorder more than anything, but you guys more than likely in nursing school have felt at least mild to moderate levels of anxiety. Maybe even severe anxiety. So some of this stuff will be not necessarily common sense, but easier to kind of get going into your mind as opposed to other topics where it's like the first time you've encountered it, or maybe you have to think about it, like schizophrenia or maybe bipolar. But yeah, so the main thing that's going on with anxiety is you have some of the neurotransmitters that are believed to be affected. Norepinephrine makes sense because norepinephrine is going to be your neurotransmitter that handles the fight or flight response, so your stress response. So anxiety is kind of just having a heightened level of that stress response kind of at all times because your body is normally meant to use anxiety as kind of like a motivator, something that's supposed to get you to focus on some sort of task that you're supposed to do. And with mild levels of anxiety, you can actually be more efficient, if anything. But when it gets past that mild level is when you start having issues and to the point where it becomes debilitating and makes a genuine impact on how you act, how you behave, the kind of work you're doing, how you do in school, etc. It's also believed that serotonin and GABA would be low. So serotonin is your mood regulator. So if that's low, you're having some issues regulating your mood. Serotonin is also kind of like one of our happy transmitters. So um, kind of having issues with that as well. GABA is your inhibitory neurotransmitter. So that being low is essentially kind of telling you like, as uh you're not really inhibiting your behaviors as much. You're not inhibiting your like what you're feeling as much. So it'd be kind of like brings forth possibility for like the racing thoughts, like intrusive racing thoughts that might be going on. Going quickly through the levels of anxiety, mild, like I mentioned, it's like optimal. You're alert, you're focused. Moderate is you're having a little bit less functionality, still able to work, but you have, it says here, decreased attention, a little bit of tunnel vision. This is where a lot of us are at clinical, a lot of us are during tests. You start tunnel visioning, and that's where some mistakes get made because you really focus in on a task, pay less attention to stuff around you, and you're going to notice yourself that function's going to decrease a bit. Severe anxiety, now that is you're going to start having that SNS response. So that fight or flight response, your heart's going to start beating fast, your pupils are going to open up. You might start hyperventilating. You might feel your heart palpitating, you might have a headache. Um, so this is where now it's really becoming debilitating. And then past that is having complete full panic attack. So this is where it gets more serious. Uh, it can get to the point where you can either faint, like a syncope due to a panic attack. It could increase your risk of suicide because you might have like abrupt, all out of nowhere thoughts of harming yourself. Um, you could be so panicked that you start having delusions. You start hallucinating. So delusions could even be something like, oh, um, I think this, even though there's no proof for it, but I think this because I'm in a complete panic. So it could be like you're in a complete panic. Let's say you're at work, you're in a complete panic with your preceptor. You make one mistake, and then you're thinking like, "Oh, I'm gonna get fired," or "I'm gonna," yeah, like say you're actually working, like you're, "Oh, I'm gonna get fired. I'm gonna get kicked out of nursing school." There's no proof about that, but you're so panicked. That's what you're thinking. It can even get to the point where you're hallucinating. So it might be kind of like the panic where you start seeing shadows. That's a common one for like anxiety hallucinations, is seeing shadows, or maybe the voices in your head, the intrusive thoughts get to a point where it's even like kind of considered like auditory hallucinations. You start hearing people talk in your head, which could just be, again, partly your mind itself racing, but kind of that stuff. And of course, that can lead to unsafe situations. Something else she kind of goes over is like the primary gains versus secondary gains. So sometimes in general, not even necessarily with just anxiety, other conditions as well. There's something to gain from having some sort of mental illness in a sense. So a primary gain is something that is um kind of like the main, like what is the, like sometimes like OCD, for example, it has like something that is impulsive but does relieve anxiety. So for example, it could be like, oh, I do my 10-minute hand washing ritual. The primary gain about it is that I get to feel relief from the anxiety that I'm feeling due to my OCD. The secondary gain then here is like any like fringe benefits that can come from having it. So for example, people kind of treat you nicer, or they're more careful around you because they're like, oh, I don't want to upset you. So I let you get away with more stuff. Like I have, um, like let's say your parents, like you maybe uh are less strict with them, give them less of a curfew, whatever. Or if it's someone, for example, that has not even just necessarily mental illness, but also um, medical stuff. That's where kind of like the Munchausen thing kind of comes in, where it's like the primary gain of me saying that I have this disease um, might just be attention. Like secondary gain could just be attention. So that could be kind of the primary gain could be like because if you have Munchausen, part of that is like you have this belief that you have these diseases. Your primary gain is kind of like you're relieving the anxiety of having it by getting treatment. Secondary gain is people treat you like you're in that sick role. People are taking care of you. So sometimes, it, people tend, are capable of using like kind of like what they're going through as a motivator to exaggerate some of what they're going through or kind of play into it because there's sometimes like that secondary gain to get from it. And not necessarily like it's kind of related. Just people, it there's like I saw a statistic not too long ago where the people in like the people that tend to fake seizures are the people that are already epileptic. That tends to be the case. So the people that have seizures from time to time tend to be the people that fake the seizures the most in like a psych facility or even in a hospital. So it's kind of like, well, I have seizures my whole life. I kind of know what happens, how people treat me after I have a seizure. So sometimes it'd be like, well, I know if they think I have a seizure, they're gonna ignore my bad behaviors. They're going to treat me nicer. I'm gonna get maybe they're gonna give me just gonna have all the nurses on me and like helping me and making me feel better. So I will pretend to have a seizure. Okay. Some types of disorders that could deal with anxiety. Um, like I was mentioning, obsessive OCD, obsessive compulsive disorder. So here's the definition: is a maybe some sort of obsession. Maybe you want to keep turning the light on and off. You want to wash your hands. You want to check that all the locks are there. So that's going to be repetitive behaviors. The important thing for testing is that you do not want to disrupt the ritual. So you might have like a test question where this person is habitually washing their hands. So what is the thing that you like? What is like the thing that you're supposed to do? Some of your choices are going to be like, oh, get them to stop doing their hand washing so they can get ready for breakfast. But what they're actually looking for in that question is going to be um, like have their breakfast like 10 minutes later, have their breakfast ready, prepared 10 minutes later so that it's hot and ready to go by the time they're done with their ritual. Because you don't want to disrupt it because that's going to stress them out. The way you're actually going to have to deal with it is going to be with medication and therapy more than anything. Generally, you can try setting limits to behavior, and that's going to be like the big key thing. when you're actually in, well, I guess they probably don't let you guys do too much stuff in clinical, but what you're supposed to do is kind of set some barriers. You always want to have boundaries, but that is very difficult to do. And then some accommodation as well for people with OCD, because the end goal is you do not want to disrupt the ritual. So that's going to be, I guarantee that that'll be like a test question down the line. Generalized anxiety disorder, that's going to be someone that has anxiety a large percentage of the time for longer than 6 months. General treatment includes SSRI and buspirone. Um, this one's actually a little off 'cause technically. First lines are going to be SSRI or buspirone typically. One of the test questions you guys probably saw was in that practice quiz had to do with someone that has a history of substance abuse. Um, and it's like what? Like, and they have anxiety, so they're not going to be given benzos because those can be abused, but they can be started on buspirone because that does not, it's not, you can't abuse buspirone. And yeah, so usually your general treatment is going to be your SSRIs, so that includes like Lexapro, Zoloft, citalopram. There is also SNRIs, so the some of the specific ones that are good for that one, and I do have it listed down there as well. Effexor and Cymbalta are FDA approved for anxiety. So even though they are SNRIs, they do impact the norepinephrine, which we already kind of see is high here. The amount it impacts is not to the point where generally the anxiety is going to get that much worse, but it could be a thing where there might be a little bit more jittery. They might feel like the anxiety is worse initially, and then it'll get better. And then the effects on Cymbalta are usually pretty good for anxiety if the SSRIs don't work. And sometimes you have to play around with different SSRIs because some of them might give you side effects, unwanted side effects. Some of them might not. But yeah, alongside that, panic disorder. So that's the intense discomfort, high risk of suicide. The main medications are going to be for long-term treatment, SSRIs, and then I would also add in benzos because they can have Xanax or they can be on Klonopin, and I have them listed down further down as medications that are used for managing anxiety. And then PTSD, um, after experiencing a traumatic event, either, could include people, war veterans, very commonly we know about PTSD. People who have been victims of physical and sexual abuse. And there's technically two types of PTSD. There's a normal, like uncomplicated versus complicated PTSD. You don't have to really get into the detail, but basically just like one's worse than the other. Some phobias that she'll probably want you to know, kind of like the idea behind. Agoraphobia. This one is a fear of crowds, fear of kind of just being around people. Uh, Social phobia is a fear of social situations. And there is also such thing as social anxiety. That one can be very common as well. Social anxiety is similar to just having fear of being in social situations because you're afraid of being rejected. You're afraid of being judged. So that could be impacting your job. It could be impacting your life because you tend people with social anxiety tend to avoid being put in situations that they don't feel like they would know. So if it's like they've never had to do like a nursing skill, they'll avoid it. They'll just be like, I guess I won't do that right now, or I won't do that today, or we'll just try to see how we can avoid doing that because I've never done it before, and I don't want my preceptor, I don't want my coworkers thinking I'm dumb. So that might be like a thought. Or you might overthink certain situations. Uh, and be like, oh, this happened, therefore I think they hate me or I think they don't like me, kind of things like that. And then Other than that, there's general specific phobias like arachnophobia, um, etc. Some treatment, CBT, that's compulsive behavioral therapy. So that is, and you're gonna want to know desensitization therapy. The idea of that one is that you're slowly exposing someone to something to try to build kind of like resistance to the stimuli. So you're not going to immediately expose them to it, but you are going to slowly start introducing it until they get more and more used to it. Kind of like test, like you're going to a pool and it's a little cold. It's cold outside. The water's kind of cold, so you're going to slowly make your way down until you feel comfortable dipping your whole body in. And same thing with phobias. You're going to slowly expose it to decrease aversion and fear. So I imagine you will have a test question on desensitization therapy, like what it is, what is effective, and usually like that's part of that's going to be effective for specific fears and specific stress responses and like how it can be used to manage it. Otherwise, there's relaxation, deep breathing, music, art, support groups, identifying your triggers, etc. Stuff that people do, some of you might do also, just to kind of ground yourself, get yourself ready to attempt to move on from whatever is causing you anxiety, or just kind of keep track of it. Okay. Any questions on anxiety in general? And then we'll go over meds. Okay. So anxiety, like I mentioned, you have SSRIs, you have SNRIs, you have buspirone, and you have some miscellaneous medications that help with anxiety, and then also you have benzos here. So definitely a lot of detail there. I do know that they'll test you on psychopharm as well. So let's take a look at SSRIs. So for those that were there on week 1, we did go over SSRIs when we talked about depression. Typically, this is a med that's used for depression, but this does have an effect on your anxiety because it modulates serotonin, which we explored up here, can be low, and that can impact how happy you are, impact how you modulate your mood, etc. So some examples of those include Lexapro, Zoloft, um, Prozac, Paxil, Celexa. I listed both the generic, and the brand names just in case. I believe, honestly, though, in the NCLEX, they only use generic names. They don't use brand names. So I would generally get myself familiar with generic names more than anything. But usually you notice that they end in pram, here, pram, or they end in oxetine. Sertraline is the one that's kind of like a rare, not a rare exception, but it's like the exception here. So some of the side effects, there's going to be a black box warning. So the idea is that you can have an increased risk of suicide risk after 2 weeks of use if that anxiety kind of comes with depression. Might give them um, the energy to kill themselves, but sometimes it might just cause suicidal ideations on someone that's never had it before. There's also some extra stuff. I think the main things to focus on is definitely the black box warning. Something that commonly causes people to, these three things commonly cause people to stop using SSRIs, not be compliant, is that they'll have a loss of libido, meaning that they won't really have an interest in romantic or sexual activities. Weight gain, it can be common with some of these SSRIs. Lexapro, for example, is more likely to cause weight gain. There are some that don't cause weight gain as much, like Zoloft is more weight neutral, but it is more expensive for that reason. Another common thing is erectile dysfunction that might get someone to be like, nah, I'm not doing this. So someone could have a erectile dysfunction without the loss of libido. So it's like they still want to do things like that, but they can't. So that might be a big thing in preventing people from wanting to take these meds. They might have to switch to a different SSRI, or they could try a different class of medication. And then it could also initially cause some disturbances to your sleep. It might cause you to be sedated initially. And then ironically, it could also cause you to become have a hard time sleeping initially. And then a lesser known one is that it can also increase your risk of bleeding, which I found out more recently, like the specific mechanics behind it. But you don't have to know the specific mechanics behind it. Uh, the shorthand is that your platelets actually use serotonin to activate their ability to aggregate. So even though this is a reuptake inhibitor, meaning that in your brain you're allowing the serotonin to stay longer, in other receptors of the body, it is preventing the ability for serotonin to be transported and therefore used for your platelet use. So that is the relationship there. I don't think they will test you on that, but that is why that happens. Okay, next medication, SNRI. So serotonin norepinephrine reuptake inhibitor. If SSRIs are not effective, you'll move on to this one. Or if the side effects are not tolerated, you can move on to this one, even though it does have a lot of the same side effects, but everybody is different. So sometimes if an SSRIs might cause you side effects, but maybe the SNRIs don't. Another reason why you might want to use it is because of the fact that it's increasing your norepinephrine. So somebody that has both anxiety and depression, uh, and has like a consistent lack of energy or a consistent lack of concentration could actually get a benefit out of the increased norepinephrine. So here's like kind of like the little mention that she always says is like SNRIs could cause a short-term increase in anxiety or jitteriness, but your body will adjust in the long term. And overall, that is the reason why both Effexor and Cymbalta are effective and FDA approved for anxiety, despite the fact that they are SNRIs. And again, here's the generic name with venlafaxine. So for SNRIs, um, vaccine is a common ending for them. So there's venlafaxine, there's venlafaxine. Yeah, Marilyn?
So you said for the SNRI, it can be counterproductive. So would you tell the patient to just keep taking it even though they're experiencing that because their body can adjust in the long run?
Definitely. So that is going to be a common teaching, not just for SNRIs, but also for SSRIs and in general for a lot of psych medications because a lot of them are not instant. They don't instantly fix you. You need have them build up in the body. Same thing with SSRIs. That's why there's that it's specifically 2 weeks of use because that's about how long it takes for you to start feeling benefits out of it.
So
So
there was a question on Kaplan,
yeah,
but maybe it's not related to this. Something in a sense of if they have like the low libido erectile, they'll tell the doctor to change it. So they'll tell the doctor to change the medication in something like that, but nothing like this.
yes. So in those cases, those are things that if you are on
Hmm.
SSRIs and you have these side effects, these will not go away. These will kind of
Okay,
remain with you.
got it.
But this is more of rather than a side effect, really, it's more like it's like being caused by the fact that you're getting more norepinephrine. So it's not necessarily a side effect. It's kind of like just what happens when your body gets more norepinephrine.
Okay,
So this
got
one,
it.
your body will adjust because it's like a natural thing that your body makes and it's a natural thing that your body regulates versus something here where it's like specific way the medication is chemically exists causes
Mhm.
these functions for whatever reason.
Okay, so in the test question, you'll just say something like, continue to take the medication and your body adjusts if there's a test question or something like that.
Yes, I would say that. Yeah, like and in general that you would want to do that with SSRIs too. It's like
Okay.
you will not feel the effects of this immediately, and you need to continue taking it unless you have some of these side effects, in which case, if they are unmanageable for you, we can titrate you back down or just kind of take you off and then find a different medication that might work.
Okay, got it.
But
Thank you.
uh-huh. And then the side effects for SNRIs are going to be you're noticing a lot of the same stuff here. The main things that are different is that you might have an increase in your blood pressure and heart rate because you're increasing norepinephrine. So what are the things that go up when you're in fight or flight? Your blood pressure and your heart rate. And nervousness slash jitteriness. A higher risk of insomnia because of the norepinephrine. But everything else is relatively the same because you're still going to have an increase in the serotonin as well. Okay, any questions on either of these two drug classes? Oh, one thing of note that I'll mention is that we mentioned up here that SSRIs can also include the oxetines. The one exception to that is duloxetine, which is not an SSRI. That's the only one that is an oxetine that is not an SSRI. So that would just keep that in mind. So the way I like to remember it is duo kind of makes me think of like duo, like the word duo, which is like double. So I think like it lives a double life. It's pretending to be SSRI, but it's actually living a double life and it's an SNRI. That's the only way I can remember that if I had to remember it. If for some reason that having to differentiate between them comes up, that's how I try to remember it. Honestly, ironically enough, usually I'm better with generic names. I find that for psych for some reason the brand names stick with me a little bit better. But yeah, for testing, I think they will usually provide both, but just know that for your NCLEX, it will be generics only. Okay, moving on to buspirone, Buspar. So this is a CNS depressant that is not a benzo and it's not a barbiturate. Both of those are medications that we know are used for people having seizures, but they can both be abused. This medication does not really have any abuse or withdrawal risk. For how it works, uh, don't have to know specifics. You can just kind of think of it as opposed to increasing your serotonin, it's more like fixing the signal, fixing the way the signaling works. So it's improving how the body uses your serotonin instead, without directly affecting it. Kind of like last week when we talked about ADHD, you have medications like your extended release clonidine and guanfacine, which kind of fine tune the norepinephrine signals, as opposed to medications like your Strattera and Wellbutrin that directly increase the norepinephrine. It's kind of a similar thing, or directly rather than directly, indirectly increase your norepinephrine in that case. Just like pretty much every other psych med, it's going to take weeks to have an effect. So this is another medication where one of the most important things to give for patient education is that it's going to take a few weeks before you start feeling an effect, but you do not want to discontinue it because otherwise you're not going to get an effect. You're not going to actually get a benefit out of it. And that's kind of the hard part with psych meds is that they require such heavy buildup, like long buildup, and people become very non-compliant with it. Because sometimes the side effects, some of the minor side effects could start happening before the therapeutic effects do. So people just like, no, I don't like this. Um, so it can be very difficult to be compliant. But yeah, this one really only manages, keep in mind, buspirone manages chronic anxiety only. So it is not something that again, because you can see that it takes 2 to 6 weeks to take an effect. This medication will not do anything for you if you're currently having an anxiety attack or having issues with anxiety. You cannot, this is not a medication that can be taken as needed. It has to be a daily routine. Um, for some considerations, you can kind of imagine with a lot of antidepressants and psych meds, you don't want to take alcohol. So that's usually, if you see that as an option, it's pretty much a given. You don't really want to take alcohol with any medication, but especially the medications that deal with um, your neurotransmitters. And then another thing is, and I guess that's another thing to include here is just the possible risk of serotonin syndrome. Um, because this medication can affect serotonin, if you have a very high dose of SSRI, it could potentiate the risk of serotonin syndrome, although serotonin syndrome is still pretty rare unless your case is being improperly managed. So you would not like, for example, being on two SSRIs, which you should not be on two SSRIs unless you're tapering off and starting another one, which does happen. And some side effects of buspirone. Buspirone is usually well tolerated, but you can have some symptoms like dizziness, headache, and nausea that might make people not want to take it, aka me. I did not like, I could, buspirone did not help me with this. Uh, these side effects made me not want to take it, so it did not help me in that case. Um, and then also on SSRIs, I did not like that it made me hungry all the time, so I stopped taking my SSRI. So, yeah, it's not just people that are really far into their condition, really severe, that are non-compliant. It could just be someone like me that has like mild to moderate anxiety that is also non-compliant just because of the side effects. So some miscellaneous medications that are used for side effects, sorry, for use for anxiety, hydroxyzine, also known as Visceral. This one I see all the time. This one is super common in where I work. Is a PRN, so as needed medication. This is a same class as benzo. It's not benzo, sorry. Same class as Benadryl. Uh, but it doesn't have like a fully sedating effect. Sorry, fully like a sleeping effect. Usually it's used for anxiety, but it definitely can help you go to sleep because it relaxes you, similar to how Benadryl can relax you, but it's not as sedating as Benadryl because you can use Benadryl straight up for like insomnia. Benadryl will knock you out for sleep, depending on the person, of course, but hydroxyzine is mainly for anxiety, but it definitely can put you to sleep because it's very relaxing. Uh, what one of my coworkers said is that like at where I work at Ocean View, this is kind of just given as like a standing PRN for everybody, 50 milligrams. But my friend, uh, oh, Cami, who is one of the instructors, she mentions how outpatient, her patients will usually take less, like a lot less than that, just because it hits them so hard. Like they'll get like they'll have a big effect off like a 5 milligram, 10 milligram hydroxyzine. And she said like she would even have a patient that would get her low dose hydroxyzine, and I guess they would get it as a tablet, and they would still cut it up because even like the full low dose would be too much for them. And then and then when you actually go to the psych hospital, the 50 milligrams sometimes barely touches anyone, doesn't do a thing. So yeah, just depends on the person, of course, depends on how anxious they are, how used to medications they are for these kind of things. Gabapentin, this one has so many functions. It can be used for nerve pain. It can be used for decreasing risk of seizures. Yeah, this can also be used for anxiety, can be used for a PRN, can be used as routine or as a PRN for anxiety. And then the way this one works, despite the fact that it has the word GABA in the name, it doesn't actually affect GABA at all. What it does instead is decrease the glutamate, which is your excitatory neurotransmitter that you typically want to, when somebody's having a seizure, is because they have too much glutamate, not enough GABA. So a lot of the medications for seizures is to increase GABA to prevent seizures. Also, this can be used for seizures too. So, uh, but instead, this one works by decreasing glutamate instead, which is the excitatory one. Other medications, you can have blood pressure medications used for anxiety. So the most common ones I see are clonidine and propranolol. These are some of the brand names. Although specifically Capve is specifically extended release clonidine that is used for ADHD. But in this case, clonidine helps because um, like what is clonidine? It's a medication that helps with blood pressure and that in way it is affecting your SNS. And we know that anxiety has that norepinephrine, which affects the SNS. So this is going to be helping with the physical symptoms of anxiety. It's going to help decrease, if we go back, like the fast heart rate, um, the jitteriness. So this is going to help decrease the stuff happening here in the SNS response. It's not really gonna have the biggest impact on your mental, but it is gonna make the physical symptoms go away, which for some people is the main thing that really bothers them. But obviously you're gonna assess the blood pressure before. Propranolol as well, same thing. Usually clonidine, you only have to look at the blood pressure first. Propranolol is a beta blocker, so you're gonna also look at the heart rate before you give. So typical parameters will be like, uh, do not give Do not give if blood pressure, systolic blood pressure is under 100. This one would probably be like under 100, or if heart rate is under 60. Typical parameters. Sometimes you'll see under 90 instead of under 100 for blood pressure, but same thing. Or you'll see a heart rate under 55 instead. Depends. Maybe if that person's baseline is already on the lower end, they might use a lower scale for their parameters. Another medication that can be used for well, honestly, this one was actually no, this one was listed under the anxiety PowerPoint, but this medication is almost never, if ever, used for anxiety. It is almost always used for insomnia, is Ambien. So this is a medication that is considered a narcotic, but Ambien is considered a narcotic, but it is not a benzo, it is not a barbiturate, and it's officially a hypnotic, meaning it puts you to sleep. Um, As for the pathway, it works on GABA receptors like benzos do. But the way it works, it hits different parts of the receptor. So the main thing it does is just put you to sleep. It does not have an effect on relaxing your muscles directly or a direct effect on reducing anxiety. So it's really just going to be for insomnia. And some of the side effects include daytime drowsiness, sleepwalking, headache, and dizziness. I think she went over this one a little bit more. I think in your in-class activity or something. She was asking if anybody had like specific stories about it or something like that. But yeah, next medication list is the benzos. So these are used for seizures because they are going to increase your GABA levels. Overall, there are CNS depressants, but they have a high risk of dependence and abuse, and you can build up tolerance to them. And this should not be a first line for anxiety because of the fact that they can be addicting. They might be used, um, you know, prescribed more commonly for like panic attack disorders. But the end idea is that if you can avoid giving someone benzos, you probably want them to not be on benzos because they can become very reliant on them, addicted to them. You can easily abuse these medications. Just like how people can abuse Adderall. So sometimes you have people that are coming in because they're literally just abusing their Adderall. Now they have to be switched to Strattera or Wellbutrin, or someone's abusing their benzos, so they have to be taking off they're going to be taking off their benzos, weaned off their benzos, and then it's like, well, now you don't have it, you can't rely on it, so you're going to have to find other ways to cope with what you're going through because you can't be trusted to be back on benzos, be something that's addicting. So if you can, you know, prevent it, you'd rather not have them be on benzos, but every once having like a Xanax every once in a while is not the worst thing in the world. You can manage it. But if you're using it every day often, then you're going to become dependent on it. And another thing is that you need to be careful with the elderly when they're on benzos because they can have an increased risk of falling. Same thing with the Ambien, on older people or even like stronger insomnia medications because they could become more sedated and have falls. One of the good things about it, I guess, to some degree, is that when it comes to like overdose, there is a reversing agent, flumanazole or romazicon. So this is like you can call it like the antidote, kind of like how Narcan exists for opioids. Here is like a list of all the main benzos that I see at work. I think the one she wants you to focus more is more like Ativan, but this is like a all-in-one kind of little guide on how that's kind of used. So Xanax, for example, for panic attacks and acute anxiety, it works that way because it's more fast acting, and it lasts like an intermediate amount of time. So if someone's having an acute panic attack, Xanax can quickly get to work on helping them feel better. Ativan, I would say the most common ones I see are Ativan and Klonopin. So Ativan used for acute agitation, is given even if someone doesn't have anxiety. It could be like if someone's just agitated due to other reasons, prone to having like alterations of mood, they can get Ativan. This medication takes a little bit longer to get working, um, but it is effective for the purpose of acute anxiety and acute agitation. Uh, Klonopin, this one's usually used for moderate chronic anxiety or managing the prevention of panic attacks. This one is not really something that you can honestly use as a PRN for anxiety because it's slow acting, but it does last in the body. So the idea is that this medication is going to regulate your chronic anxiety. Another benzo, Librium, chlorodiazepoxide. This one used to have a use for anxiety, but now it's pretty much exclusively used for alcohol withdrawal. You don't really need to know this one really. Diazepam, Valium, main use is seizures, but I have seen it for very severe acute anxiety. But usually try to avoid it for that because one, it hits you really fast and it lasts a pretty long time in the body. Okay. Is there any questions on anything we've gone over so far? Okay. Next thing is personality disorders. Some of the main traits and a lot of them have manipulative behaviors. They're chronic, like you're not just gonna get rid of it. You can't really treat a personality disorder without therapy. Even then, like it's something that just kind of is how it is. It's just you're not really gonna get rid of it fully. And usually, it's not just some of these behaviors you'll see are not just manipulative. They can be very self-centered. A lot of the time, though, they come from childhood trauma, like abuse. Sometimes it's genetic. Sometimes it can come from improper child rearing, where they learn bad habits, or uh, just from what they go through, they regulate themselves differently. They have thoughts in their head that force them, like make them act a certain way. So some of the ways I try to remember these, so they're kind of split into clusters. I think your main one for focus is going to be your cluster Bs, but cluster A, A is for afraid and awkward. So that includes people that have a paranoid personality disorder, that they constantly think other people are going to take advantage of them. They don't trust other people. A schizoid personality disorder, which is not to be confused with schizophrenia or schizoaffective or schizotypal. This is kind of just talking about someone that has poor social skills, they're isolative, and they have a lot of the negative symptoms of schizophrenia, which is like your A. So like find no pleasure in things, lack of energy. So kind of like the combination of those negative symptoms with like poor social skills, etc. Cluster B, B for the B word, because they're dramatic, they're emotional, they're erratic. This is the one you're gonna focus more on, is your cluster Bs. So that includes things like antisocial personality disorder. So one of the things to note is that this is more common in men. This is like Jeffrey Dahmer type thing, like lack of empathy for others, kind of like what people um kind of offhand refer to as like a psychopath. So I would say this is important to remember is that the antisocial personality disorder, they think a lot about personal gain. They exploit other people. These people are more likely to become aggressive or violent. So I would remember this right here, these two things. They're more likely to exploit other people and hurt people because they lack empathy and they don't believe rules apply to them. Uh, Borderline personality disorder is more common in women and very typically due to a history of sexual abuse. This can be described as a manipulative, like having manipulative behaviors. But it is worth noting that for borderline people, it's kind of like they feel like their emotions are just very heightened. So they can feel a lot of attachment to people, uh, and they kind of like implant themselves onto people, like, oh, you're my person now. And they try to do, they'll do things for you, or like they'll draw you pictures. They'll try to give you gifts, or they try to like favor you over other people. Uh, but then they kind of like almost expect the same level of adoration back towards them. And if they don't get it, like they have heightened emotional attachment, heightened emotional feelings, they'll feel like you just betrayed them. So this can come off as very manipulative, but for a lot of these people, it's not necessarily they're being sometimes they're being genuine. It's just how their brain works, how their body or their brain and mind functions. They just think everything in like extremes. They will genuinely feel distressed. An example I can give is we had a patient that was very, very manic, but also very, very attached. So he implanted himself onto me. So he would go around telling people that I was his husband, and he would draw me so many pictures, like every 30 minutes, he would draw me a new picture. Um, there was one day where we were giving report. So I went to the other unit to give report. And I guess one of the other patients told him, he's like, oh, he's gonna leave without saying goodbye to you. So he runs over to the other side of the unit and starts knocking on the glass because he's like, you're just gonna leave without saying bye to me? And we're in the middle of report, so I just tell him like, one, don't tap on the glass. Like, two, we're busy. You're gonna have to you have to wait or something like that. And like that was like the one of the first times that I've actually, set boundaries with him. So to him, that was like the most shocking thing that's happened. So from what I heard is after we gave shift report that he was crying and upset for like the next 2 or 3 days. And he kept like really focusing in on someone said that they heard him being like he was supposed to be my husband while crying. So sometimes like I said, it doesn't have to be manipulative. Like in this case, like him crying and him having those thoughts, I wasn't there for that. I wasn't there to give him that attention. So he was genuinely feeling those feelings of betrayal, genuinely feeling betrayed in that sense, because he just has like a heightened sense of emotion due to having borderline personality disorder. So I would rephrase. This is like an old little thing here. So um, behavior that can be as manipulative, and sometimes it can just be manipulated. So yeah. So with one of my coworkers who is actually really good with borderline people, says like a really big tip is one, you have to be consistent with them. You have to be firm with them. So you have to set boundaries, which, can be really hard. Um, but one of the big tips is also any compliments they give you, any like negative pushback they give you because you're setting boundaries, don't take any of that personally. And then at work, he gets called the borderline whisperer. So uh, he also says like sometimes you just gotta be borderline right back. Just gotta give them that same energy, and they'll love you, and they'll you can kind of get them to take their meds if they're uncompliant more often. Uh, you might be able to get them to do certain things that maybe they're not doing because you'll be like, well, I don't like. Well, it's like, well, I don't like people who don't shower. So it'd be like, oh, I'll shower right now. You know. So that's kind of something that can kind of come up. So it's like sometimes you gotta be borderline right back to them. But yeah, something that gets put here. This is gonna be your big thing here, as being consistent and firm. Being firm boundaries is gonna be a very common answer choice during your test for people that have borderline slash any personality disorder. So it'll just be a big thing is like setting hard boundaries, not allowing like someone says staff splitting is common. So like someone being like, well, the other charge nurse told me that I can do this or I can have that or I can do this way. You just gotta be consistent with yourself, with what your own decisions are and set those boundaries because other it's kind of like you give them an inch, they take a mile. But because they have this heightened sense of like trust and attachment, and they can have like manipulative behaviors, sensitive behaviors. They're also at a higher risk for hurting themselves because or violence. So kind of like threatening like, oh well, I'm gonna kill myself or I'm gonna hurt myself because you're not giving me this. So that's just kind of one of the things to think about. Next one is histrionic. This one is kind of like attention seekers. They dramatize things to make themselves look better. So like the PTA mom is like the one she usually talks about. Usually comes from a lack of self-esteem. So it's kind of like not it's not quite the same as antisocial personality because antisocial personality is like well, there's also narcissistic personality disorder, which is down here, which is like also self-centered, but this one's kind of like it's like seeking for attention, uh, as opposed to like, oh, I'm the best, I do everything well, there's no one better than me. This one's just kind of like not necessarily has to come with that, but it's like I want people to pay attention to me. Caitlin in the back said, it's like someone that's at the bar and she decides that I want to sing louder than everybody else because I want all eyes on me. The way I think of it is like the word hiss, hiss. I just think this person wants to be him. So that's why they're always seeking attention. They want to be him. Mhm. Um, Caitlin was mentioning that there's a Netflix documentary. I think it's called Unknown Number. And I won't spoil it, but one of the characters there, or not characters, actually a real person, is basically, but like textbook histrionic, attention seeking, even though it's literally they have no reason to be. But so that's kind of like an example. Narcissistic personality disorder. This one is again self-centered. I'm sure you guys have encountered narcissist. Um, they can be manipulative for self-gain, but they will not cause harm as opposed to like antisocial. They don't care. They will do whatever they need to get their way. Narcissist um likely will not cause harm because like having that positive image of themselves is also another thing they're looking for. So like if they were to cause harm, people will look at them as lesser or they will judge them a certain way, and this person is all about appearances and coming off like, yeah, I'm like the best person ever. Although it's commonly found that people with nar that are narcissists tend to also be have low self-esteem. Right? So again, cluster B is like the main thing to focus on. Then there's cluster C. C for lack of confidence. So there's avoidant personality disorder. So this is different from antisocial because you're lacking good relationships. Not because you don't want to have relationships, because you're afraid of being rejected. So you might be withdrawn. But you do want relationships, you're just afraid of them. Dependent personality disorder. This person relies on other people, has no self-confidence, is like being codependent. Like just like you would be like, oh, I need this other person or I can't do anything. I need to rely on this person. Then there's obsessive compulsive personality disorder, which is not OCD. I know it sounds like it, but OCD is like very ritualistic, very compulsive. Like you literally have no choice. As opposed to like, no, someone that's like, I like all my pencils organized a certain way. Not necessarily OCD. Maybe they're autistic, to be honest, but it could just be like obsessive compulsive personality disorder. So they're very rigid. They have a few rules that they set, either that rules that are already established or they set for themselves and they want to follow it, but not to the point where it's like ritualistic. So for this, the goals are controlling your impulses, how you express yourself, gaining more trust, etc. Here, interventions, there's not really any medications other than like treating underlying depression or anxiety. The main thing is going to be psychotherapy. So if you get a question, your main intervention is going to be psychotherapy. And again, setting limits and redirecting is going to be your big thing. Any questions on personality disorders? Otherwise, we'll quickly go through eating disorders. Okay. So anorexia nervosa, this is such a common thing in media. I'm sure we kind of already have an idea about it. These are people that are afraid of gaining weight. So they either they restrict, they overexercise because they have body dysmorphia, meaning that they see their body as different than what it actually is. So like it could be someone that's already skin and bones, but they see themselves as being fat. So some of the manifestations, of course, are going to be emaciated, meaning that they're severely malnourished and underweight. That also impacts your vital signs. So you're going to have a decrease in heart rate, decrease in respiration rate, decrease in blood pressure because you don't have enough mass essentially to require the same level of calories. So like your base metabolic rate goes down, your body leads kind of is just less energy to do things and it requires less. So you're gonna see a decrease in heart rate, respiration, blood pressure. They're gonna have less body fat, which means they don't insulate as well, so you're gonna be cold more often. One of the things that could happen is called lanugo. So it is like really small hairs, kind of like the body trying to compensate, and it's literally like a baby thing, trying to compensate and keep itself warm, so it gets like really thin hair growth because they're not uh, nourishing themselves properly. They can have brittle hair and nails because they're lacking vitamins. They have dry skin because they're lacking vitamins. And it could get to the point where the body doesn't have enough resources to even, like for women, have periods. Um, or even just be able to like have children. You could become infertile. And then the key thing, of course, is the obsession with food. They're hoarding or concealing food. So they might get food and then they'll pretend like they ate it. They'll hide it. So it looks like they ate it or something like that. They get their plate. They're like, oh, okay, I'll eat in my room, and then they'll like throw it away in the trash can and just pretend like they ate it. But yeah, generally obsessed with food. Decrease in vital signs. So I'll put that. General like malnourishment stuff. So kind of all these kind of go with malnourishment stuff. Body dysmorphia is a big thing here. They have negative body image. Here, obsession with food. And then this is important. This is kind of like their main thing. Okay. In terms of criteria for hospitalization, I would not memorize this, to be honest. Like I would say just kind of get the general idea. So low vital signs, like we mentioned, anemic from the lack of resources. And in case for like hospitalization, it'd be like they're so anemic, as you can see here, that they would need like blood transfusion because they're so anemic, because they're so malnourished. They need fluids. And then of course we know that when people are malnourished or not eating, hypokalemia can be a big thing. Um, Properly malnourished, not getting the body is not getting the nutrients it needs. You could have arrhythmias from just things not working right. And of course, suicidal thoughts can be another big thing because they hate themselves, they hate their bodies. So they can start having thoughts of hurting themselves. They might like be unable to cope with despite the fact that they're restricting already, they're not eating, they're exercising, they might not be able to cope still, they cut themselves. So those kind of things. But I would just focus on the general idea and having like a general idea of when is it to the point where it's that bad. And that would be supremely low vitals, anemia, hypokalemia, suicidal thoughts are probably going to be the main, and arrhythmias are probably going to be your main, I'll probably do here. Boom. Probably like the main things that causes someone to get hospitalized outside, as opposed to being like an treated outpatient. Bulimia, this one's going to be ingesting food and then purging. So one of the things you see with this is going to be due to the fact that they are purging, they're throwing up, they're getting all that acid, so they're going to have increased instances of mouth sores, inflammation of their esophagus, and this is another really big one is decaying of teeth because of all the acid eroding their teeth. So this is going to be a big thing, manifestation. One of the things about bulimia is that their weight is typically not is like usually within like usually pretty normal, partly because for the most part, I mean, by the time a lot of them make themselves vomit, their body's already absorbed the majority of the nutrients, so they're vomiting to get some of it out. They're not actually reducing how much they're getting by a too significant of an amount. So for that reason, they're not really losing too much weight. But obviously they're vomiting, so they're going to be dehydrated. They're going to be specified for hypokalemia specifically. Hypokalemia, because they're vomiting. We know that's a common cause of hypokalemia. They could be acid-base imbalance because you're getting rid of acid. So alkalosis is where that comes in. Again, with the not well, kind of some degree malnourishment or anything like that. It can come with for women irregular periods or lack of periods. And then again, going back to the criteria for hospitalization, but low potassium, fainting, risk of suicide. And then this one's like more bulimia specific. So I know the other one's pretty similar. Esophageal tears from all that damage, because that could be a source of bleeding, internal bleeding. Another thing that's not really listed here but could be relevant is that someone that is constantly making themselves throw up. Same thing with like someone that has like unmanaged GERD, is that all that damage to the esophagus causes scarring, tissue scarring in the throat. That could also increase your risk of getting throat cancer. And then here, I mentioned the Russell sign here. It's kind of like callus on the knuckles because you're shoving your whole fist down there and it's kind of hitting against the teeth. Okay, last one is binge eating. So just eating an insane amount of food all at once without throwing up, which could be done for emotional distress. So because they're binge eating and they're not purging, they're more likely to be overweight. They'll definitely try to eat in secrecy. Kind of all of these, they're kind of has like some secrecy kind of to it. This person is gonna be secretive about when they eat, and they kind of pretend like they're not eating. Bulimia, they'll be kind of secretive about after they're done eating because they're gonna try to vomit. So some of your interventions might be like monitoring the patient for like the next hour or so after you witness them eating. Binge eating, it'd be like monitoring what they're eating because they're eating way too much all at once. But yeah, some things that come with it is that they feel guilty after binging because it's kind of like, damn, this was all an impulse and I did this to myself. They're probably going to be also pretty focused on their weight. So yeah. Generally though, the main thing is going to always be safety ABCs. So of course, with some of the ones where like you can have bleeding risk, where you can have um bleeding risk and like low blood pressure and stuff from dehydration, malnutrition, um, all that stuff, electrolyte imbalances. So the main thing is that all of this kind of stems from anxiety, depression. This is its own mental illness to pretty much like the kind of like the thought process behind it. So you're really gonna have to do some like CBT therapy. Other than that, it's really going to be maybe treating the depression, anxiety with some medications, going to therapy, supplementing with vitamins, Pedialyte, etc. Maybe getting their potassium replaced. But that's kind of the general thing. So I would say out of all of these, I would say just kind of know the general idea behind your eating disorders. For your personality, focus mostly on cluster Bs. And then for your anxiety, definitely focus on the meds and just kind of get that focus on desensitization therapy for like your phobias. Know your agoraphobia because that one gets tested on, if I recall. Um, know the general stuff that kind of goes with anxiety. Definitely when it comes to OCD, you do not disrupt the ritual. That's important. Yeah, get a general idea of like your anxiety levels. Don't hard memorize it. But yeah, other than that, I think that's pretty much it. Any questions on anything? All right, if there's no questions, we'll end up. I'll give you guys the file and then we're good to go. Good luck on the test.